Bunning, today's presenter. Dr. Bunning has directed the arthritis program at the National Rehabilitation Hospital since 1986. He is board certified in internal medicine and rheumatology and a fellow of the American College of Physicians and the American College of Rheumatology. He has a traditional practice treating arthritis with additional expertise in exercise therapy and the use of the rehabilitation team. Dr. Bunning's other clinical interests include gout, rheumatoid arthritis, lupus, and muscle disease. He has an extensive experience in maximizing outcomes after total joint replacement using a rehabilitation program. Dr. Bunning is a past president of the rehabilitation section of the DC Rheumatism Society and has served on the executive committee of the American College of Rheumatology for 3 years. He also served as a member of the medical board of the DC chapter of the Arthritis Foundation. He is on the clinical faculty of Georgetown University and is a former chief medical resident of the Washington Hospital Center. His undergraduate degree is from Princeton University and his medical degree is from the University of Cincinnati. Now I will turn the floor over to Dr. Bunning.
Thank you, Alina, for that very nice introduction. I read it just as my mother wrote it out. I appreciate that. But let's get going because we got a little bit to cover. Reaching out, very rewarding experience. Everybody up to speed with this question. So, gout is a goal of years of education to improve the diagnosis and treatment of post-menopausal women. I understand you have a grant from AstraZeneca to stop you pharmaceuticals that help to pay for this. This program was put together by a number of faculty, 5 our objectives: identify musculoskeletal disorders associated with menopause, differentiate ones that are not gout from gout, create pharmacological, non-pharmacological treatment. So what happens in menopause? Probably the audience knows better than I do, but there is a loss of muscle, weakness, atrophy, falls, there's loss of bone mineral density, increased osteopenia, fibrosis, wrist fractures, hand fractures, and there may be vertigo that accompanies vasomotor also. Menopause is associated with musculoskeletal disorders. There's probably an increased incidence of joint musculoskeletal pain. With the reduction in estrogen levels, there's more pain and stiffness. The reduced estrogen also is associated with inflammatory processes and elevated serum uric acid levels. Estrogen helps uric acid excretion, helps it be excreted from the kidney. It's a very strong uricosuric agent. That is why gout is almost unheard of in premenopause. And in fact, any young woman with gout almost always has estrogen. Hormone therapy, weight loss, and physical activity can reduce muscle. So there's a somewhat arbitrary slide, inflammatory, non-inflammatory. I think fibromyalgia is the best to understand it. Osteoporosis are not very inflammatory. Osteoarthritis sometimes can be an inflammatory condition. However, when you have a swollen knee with osteoarthritis, you won't have nearly as many white cells than if you have a knee with gout infection. Polyarthralgia means polyarthritis. The word arthritis actually means inflammation. It's a little bit of a paradox in the way to describe it. Polyarthralgia rheumatica is not thought of as a strong inflammatory condition. So these are the more classic inflammatory conditions, more inflammatory than the previous slide. Although we were talking about good and bad things about menopause, one of the good things about it is autoimmune usually occur before menopause. These are frequently used after menopause, lack of estrogen policy, or yes, something that doesn't occur, but it's very inflammatory. People talk more about that. Calcium pyruvate, very similar to gout, also an inflammatory illness. Unlike gout, on the onset, it may frequently gout is fairly acute arthritis may be favored the wrist more than the foot. Gout is favored the lower extremity. Ankylosing spondylitis is a little more common in men than women. It can also occur in women. The onset can be before menopause, but the symptoms can progress and become more apparent later. So now on to gout. One of my favorite diseases to talk about has a great history. Of course, Hippocrates in around 500, 600 BC wrote aphorisms about gout. It's known as the disease of kings. In men, usually middle-aged men at the onset, and in women, a couple of years after menopause, maybe up to 10 years after menopause. The reason women get it later is, as I said, the presence of estrogen protects them in a very strong way. Estrogen is uric acid. It's caused by uric acid serum levels rising to the point where crystals form, deposit themselves in connective tissue diseases. After a certain amount of time, enough accumulates, one breaks off and we have an attack. At least 50% of the time, the plastic attack, first attack is big toe, diagram, foot traps, miracle trap. It hurts a lot at first. In hospitalized patients, it might be polyarticular. But for an outpatient, usually one joint. And I think this slide's a little busy, but I think if we just summarize, 4% of the adult population has gout, so it's not uncommon, and it's going up a little bit, even coming talking about why. So there is an increase in self-reported cases, which is not surprising. I think there is a real increase in education also makes sense. And rheumatoid arthritis, which is perhaps more visible on an ongoing basis, emergency. Again, the age of onset, middle age, 40s to 50s in men, maybe 60s in women. And before menopause, as I said, almost the male to female ratio is almost, there are no once you get to your 50s, male to female ratio is either 4 to 1, and as the patients, as women have longer period of time in menopause, catch up a little, never quite. Why gout just syrups, gout, there's a lot of those around, although people are starting to stop using them so much. Increased longevity, good, increase with time, are a couple of reasons. Increasing rate of comorbidity, as you get older, you get more comorbidity, so hypertension is a risk factor that increases with age, diminishing kidney filtration increases with age, and there's an increasing rate of obesity, which is a risk factor for gout. That's one of the reasons we're seeing more of some of the reasons. Again, it's more common in men, but women certainly get this. And here's some numbers that give you some idea. It's not rare even in women, and that if you use hormone therapy, that's the reason they've already covered both increases. What causes gout? Probably this audience is pretty medical. Just to review. Normally, everybody has uric acid in their body. It's dissolved in the serum. But when you get to in the body a level of 6.8 concentration, crystals form. They deposit in soft tissues. They accumulate gradually over years, and then they get to the point where they start breaking off and you have an acute attack. If you don't do anything to lower the uric acid level in the serum, more and more crystals deposit. The rest of the sleep linkage more and more intact. That's initially called the intercritical phase, but then when you have one attack after another, it's called depressive disease. And every rheumatologist is years of arthritis would actually think that gout was caused at the beginning. And at the end, bad gout would look like that. In fact, it often did up until 1955, when we had no agents to lower uric acid until 1955. Benamid, 5 urinol, and somewhere about 5 years ago, we got an agent similar to allopurinol, but caloric, or the trade chemically, buxostat, which works like allopurinol. So gout is a miserable, progressively unstable form of pain. Unfortunately, we can prevent that as long as we make the right diagnosis. So we mentioned risk factors for gout. I mean, it's almost you can't have gout without high serum uric acid. It's a pretty strong risk factor. Although in the initial attack, we draw serum uric acid might affect that. There are comorbid health conditions that are risk factors. Obesity is known to be a risk factor. Alcoholism, especially beer drinking, rich foods, kidney disease with the decreased glomerular filtration. There's some medicines we're going to talk about. I think the next slide covers that. And on the alcohol, we mentioned especially beer, mineral spirits, spirit whiskey, for example, about half as strong as beer. Fortunately, for me and for some of my friends, red wine is lately uncareful in the etiological study. Not found to be that much. Certain medicines contribute to gout, and one of the reasons gout is increasing low-dose aspirin. Low-dose aspirin will elevate uric acid. Diuretics, especially elevate uric acid levels. For certain transplant patients, it's cyclosporin. You can get very fulminant gout within a year or two. It's very strong effect of cyclosporin in elevating serum uric acid. Conventional grade, rich foods. Leah, I think you were going to take us through this polling question.
Yes, I am. So our first polling question is, which one of the following statements is true? Women are more likely to develop gout at a younger age than men, who are more commonly diagnosed around age 6. Males are more 60, Males are more likely to develop gout at a younger age than women, who are more commonly diagnosed about 10 years post-menopause. And women and men develop gout around the same age.
I think we have a very smart audience, Leah.
We do.
I don't know if they can see the results, but I'm seeing so far. Just getting across.
Yes, it looks as though it is.
Right. So, just to sort of restate some things, men get it younger. Obesity is a risk factor. Alcohol is a risk factor. You need more frequently. And women, you more frequently use diuretics, pre-existing joint disease. Of course, they're going to be older when they get it, so that's surprising. Both men and women can have a family history. I haven't really seen or reviewed the data that is a stronger risk factor in women than risk factor in men too. But renal insufficiency certainly I've seen women who actually don't have gout but on diuretics develop gout. More women are on diuretics. So we did mention that it comes on quite suddenly, typically, especially in the first attack. My mentor used to say, gout comes to the emergency room with fighters or reactive arthritis make an appointment. Many other types of arthritis make an appointment, but not gout. When you wake up in the morning, they say, it hurts the sheet on the bed, somebody walks in the room, and that you don't treat, you don't do anything, gout miraculously doesn't go away. Initial attacks, maybe as soon as 3 days, usually within 5 to 15 days, we try to speed it up going away by giving treatments we'll talk about later. but it is an arthritis that's not common. Episodic or can become chronic or can continue to form. So we have a pretty typical case here. You go to our accountant, right grade toe pain, and address and walking in milk. Oh, it's gout is like walking on an island. No known injury. Aspirin helping get low dose would make your gas go up. High dose aspirin is anti-inflammatory. It's a little risky for the stomach to generally like aspirin as an anti-inflammatory. And Meg is not one that the exercise can. So what are the consequences of this act? You can't walk around, you may have to do work, with your friends, and you're going to start using healthcare quality of life. What causes this? Well, Meg, it could be anything. But the way it was described, I was limited somewhat. I mean, general differential diagnosis for gout. But in fact, arthritis really doesn't like that. More risk of small joints, chronic anatomy, not sudden. Psoriatic arthritis can present no pain. Any can arthritis related to lymphadenopathy. That can be one that's tough to think about to figure out. In the back of your mind, you can keep that in mind. And also, sudoku gout could affect the great toe. As I said before, it's typically more upper wrist joint sudoku gout, but also shoulder or knee. Occasionally, though, it could be the big toe. And bursitis could be bursitis without septic arthritis is very rare in both organs. Compromised. Cellulitis, though, is always looks like food. It's always red. Occasionally, we can get it for both if we're not sure. When people have dry skin, cracked skin, violated immunosuppressant or cellulitis, those people might end up using both. Certainly, stubbing your toe make them like gout. You usually remember. So this is a slide that's basically, I think, so many words. You can make gout if you want, but if you don't want to, you can go to a dermatologist or even an internist with an treating gout. It's not that hard to learn to treat yourself. Take it off. Treating acute gout, just treating the pain is pretty simple. Deciding when to use it, though it gets a little complicated. Like give So the traditional gold standard for diagnosing it is taking fluid out of the tooth, crystals under the fluorescence microscope. In fact, that's done less and less. I think there are other ways of diagnosing gout are better and better. Nobody likes to get the needle in the throat that's already hurting like crazy, but it is the gold standard. Often from the history of physical, perhaps one lab test, you have a very good idea of the diagnosis. As I said before, for reasons that are a little complicated, sometimes the serum uric acid level will drop a little bit during acute attacks. I would still draw it, elevated. You've got your supporting data for the diagnosis. It's normal in your puzzle. You're not sure of the diagnosis. Later, it's elevated then. It would be supported. Plain x-rays in the first attack often don't feel much. You might be swelling. Depending on how long the crystal is accumulating, you might calcification. Ultrasound is a fairly useful way. There's been patterns you can see with gout. Not everybody slapping an ultrasound on their wrist, but certain rheumatologists decide just like to use the ultrasound carried around the exam room. It can help strengthen your diagnosis. MRI is not generally used as a way to use it. Might see erosion. CT scan, there's a dual energy CT scan that surgery actually shows up crystals in serum beautifully, but that's not really a practical way. Gout generally isn't that hard. But you might get X-rays, you know what it is, see if there are any erosions in the bone. There are erosions suggestive of gout, topi, another reason to use the agent. white cell count normal. That was serum uric acid 9.7. So I mentioned that above 6.8 start forming crystals. The higher it goes, the more crystals you get. 9.7 micrograms is a pretty high level. All very suggestive of gout. So our first goal would be to put the fire out. We need a consult to get it. Tell her about what she can do with diet and lifestyle that might help treat gout, and then try to figure out why you're getting secondary results. You can change. For example, if it's hypertension, intensive on diuretic, we might be treating recommendations. So as it says, switch medication if you can. That would be aspirin, diuretic, Lizobil, and as I mentioned, like other often you need that. Right? Looking at things. Then you say how many crystals are in there, how likely is it to be tagged. If we jump in now with the you can do the target is all the guidelines by various hematology methods. So what do you do for the acute attack? I think what do you do to put out the fire? I think if it's not too bad, you try one thing. There are three things you can use on the menu. You can use an NSAID, topical or by mouth. You can use prednisone, low dose. Or if it's a very bad case, you can even use a more dose. Or you can use colchicine, which has been around for a long time. Lots of times people have been frank with terrible. And used in the United States ever since. Only recently, the FDA in about 2006 said, even though this medicine's been around, we noticed it's never really been studied and we're not happy with that. So they asked any drug company to actually do the studies, which is called $80 million, which is why colchicine used to be called 6 cents a tablet. Now it's called $6 a tablet. It's called Colchris. But any of those three things can be used for acute gout. Colchicine, an NSAID, topical or by mouth. I like for a topical NSAID, we have like cloconam gel or prednisone. I try not to use high-dose prednisone. Diabetic patients, prednisone problem. If there's renal insufficiency, NSAIDs by mouth can be a problem. Colchicine at full dose, you have to adjust colchicine longer for renal insufficiency. One other thing about colchicine, for many, many years, the textbooks said give like 1 tablet an hour until they're better, or until the patient gets diarrhea. And I don't have time to go into why that's such an absurd recommendation, why it's stuck around for so long. But when colchicine got studied for approval to the FDA, people studying it realized that wasn't a good idea. They did study it that way, but compared it to 2 pills, one pill an hour later, and then 1 pill twice a day. And not surprised that better to give 2 pills at once than 1 pill, rather than push it to the patient. It's horrible to have diarrhea when you're hopping around. And why it was started that way is a very long story, but it wasn't a good idea. We don't do it anymore. Some medicines can also interact with colchicine by accident, for example. So if you're using colchicine, make sure you review all the medicine interactions. Leah, I get to rest my voice for a minute.
Yes, you do, just for a moment. Which of the following non-pharmacologic interventions should be considered in a treatment plan for patients with gout? Avoid organ meat high in purine content, such as sweetbreads, liver, and kidney. Reduce or eliminate foods high in high fructose corn syrup. Discontinue excessive consumption of alcohol, particularly beer. Increase consumption of low-fat or non-fat dairy products and vegetables. All of the above. Well, it looks like you're doing a great job. It looks like we're getting the correct answers.
Yeah, and that's good because I actually didn't say that specifically, although it was slide picture. They had a picture of sweetbreads, liver, and kidney, but I didn't exactly point them out. And they had a picture of the low-fat, non-fat dairy products and vegetables. I don't think I specifically stated them, but these people are not only listening to me, they're looking at the slides, and that's great. Good visuals from the slides.
Yes.
All right. We're more than halfway through here. We definitely want to leave time for questions, by the way. If you're thinking of a question, go ahead and type it in now. But I really like people who are listening who have any questions they have. Oh, here's our picture that I was talking about. There's another picture. So avoid the organ meat. Um, watch out for too much alcohol, especially beer. High fructose corn syrup is not good. And low or no fat dairy and vegetables are and I'll just comment. A lot of patients say, "What can I do other than take a pill?" A lot of patients are like that. The thing is, everything but medicine can really even combine and only lower your uric acid in one. So if your target 6.8, and you're anything higher than 7.8, you're not going to get the target doing all of these things. Just there are studies that show that. So if they come in like Meg with 9.8, and she's got multiple attacks, you want to lower her uric acid target, you are going to need. Unfortunately, we have those situations. Smoking, I don't think it causes gout, but it's always increased hydration. That can be good, especially if you have a high uric acid, you have an increased risk of uric acid kidney stones, uric acid kidney stones, uric acid resistance pneumonitis from calcium stones. So kidney stones are very common in gout patients. Some of them are uric acid, some of them are calcium stones, but kidney stones to me is one of the indications that starts with and you have kidney stones or gout with hydration. Of course, these days, everybody wants to do that. Physical activity, you gotta like it. That by itself won't make gout go away, though. Weight loss might lower your uric. So back to Meg, better off the hydroperoxide, especially when you give her naproxen, which is called the starting dose every 8 weeks. That's not a bad plan. You can either do that alone, or you could also do colchicine. Remember not to give it to diarrhea. Give 2 tablets at first, and then one an hour later. That's very effective. And then one twice a day until she's feeling better. Take the colchicine and take the naproxen. Tell her about all the other things. So now, if all these people come out, you have one attack, or maybe one attack 8 years later, put them on medicine right away to lower their uric acid rates. Add up the risk factors or estimate the probability of them having more, or estimate how inconvenient it was to have even that one. And that's really what rheumatologists do. They sort of do all those things. If we know of kidney stones, or on our exam, we find a little marble-sized thing under the skin of the elbow, or a yellowish dot in the earlobe, and opus. Those two automatically should get it. Right? If they have moderate kidney disease and hypertension, or they're having, they say here more than 2 attacks per year, but more attacks than they want to have. Very stressful. Especially, I like having an opera singer on TV. She cannot afford to get a gout attack during the opera. So she said, "I'm not waiting for the next attack." We absolutely have to prevent that. Some patients maybe have one attack after an operation. It might be a while. Make sure they have start quickly. The other thing I'll say is the uric acid level is very high. The amount of elevation is important to the risk of another attack. They come in with the uric acid at 12, just on the basis they're likely to have more, I would treat them. Some people think that there might be a risk of kidney disease or very high uric acid levels. So, for example, Betty, 56, has middle finger acute arthritis, but that's the third attack she's had. They're getting more frequent and worse. She's upset. And so basically it looks like a very swollen joint. Again, pretty high elevation, 8.9. And somebody had an ultrasound machine, and it showed inflammation and maybe this rim pattern and maybe some pattern that's with this focus. probably has gout. So one thing to think about is people come in for other reasons. Might be asking about acute arthritis. Maybe they're having gout and they don't recognize it. For example, some previous slide here, you might not think of gout in the upper extremity as being typical usually. Like what happened to our big toes here with that. You might ask people, are they having acute episodes of arthritis, different distinct pains? And then if they are, are they on a diuretic or low dose aspirin? Just a reminder from put that in there a couple times, but it's been experts for so long. A lot of people still do that. And if they're having a lot of attacks and you're not comfortable lowering your expressions. Another one of these busy slides. So what do you? There's really three things out there now. As I said, Urinol, or Benamid. Benamid doesn't work too well unless the kidneys are functioning well. And we don't use Benamid for GOPI, kidney disease. So there's a few people we tried Benamid, but we do much better getting a target with the allopurinol. It's a stat. I've been trying Benamid. Otherwise, seems reasonable. And you want to push to get it less than 6. You want to protect people from gout attacks while you initiate therapy. When you start putting them allopurinol or Uloric, they're going to tend to have gout attacks. When they pushed Uloric to the FDA, initially they only gave a medicine to prevent the acute attacks for 6 weeks because that really wasn't long enough. Now they're maybe 3 months. We'll just use tablets with the allopurinol or an NSAID or low-dose prednisone. You should definitely warn the patients when you start these agents. You can trigger gout attacks. And then if you have an allergy to allopurinol, if it's a stat or something, then you have some very unusual circumstances where it's not working. There is medicine now that can be given intravenously called Gout, regulated uricase. This is not used that often. It's not easy to use. So I would leave that to a rheumatologist. I wouldn't give up on anybody. So Betty got napkin colchicine, got better, and probably said, let's go with the allopurinol. That's been around since 1995. Dose range is usually 300 to 800 milligrams a day. Most people do well 300. It does come in 100 milligram pills, so we tend to start it at low dose, 100 per week, 100 per week, and then go to 300 to check to see if we're target. Per 4-week follow-up, it's like 7 weeks. This is our target, 6. So this doctor added on Benamid. You could have also gone 400 on the other year. Follow-up at the target. The Uloric, I think most people now use allopurinol has to be adjusted. It can be so tricky, less expensive, but I think it's rheumatologists like Uloric. Either Uloric or allopurinol, you can get a bad rash. You have to warn them about it, tell them to stop. So chronic gout, you want to lower your gas 6. How long? Discussion. Right now, you want to get it under 6. And if you don't treat gout, continue going to gradually all deposition erosion and chronic inflammation. There's no reason to let that. And we have, I mentioned the slides that will be available. Anybody interested? Plenty online about gout. I have some questions. Leah, is it okay if I go to this question?
Yes, I was actually just going to say that was the last slide, and then also say that we're going to go ahead into the question and answer portion at this point.
Right.